Hello and welcome to our live webcast. Light chain amyloidosis. What is the L anyway? Thank you for joining us. My name is Tyler and I will be the operator for the presentation today. Before we get started, I would like to take a moment to acquaint you with a few features of this web event technology. At any time, you may adjust your audio using any computer volume settings that you may have. During this presentation, you will see the following multiple choice questions during the event. To participate in the polls, please select the button to the right that best represents your views or experiences. On the right-hand side of your screen, you will see the text chat window. There is a large window which holds all of your sent messages and a smaller text box at the bottom where you will type in your questions. To send a question, click in the text box and type your text. When finished, click the send button. All questions that you submit are only seen by today's presenters. Your questions will be responded to in the order in which they were received and will be addressed at the end of the presentation. At the conclusion of today's program, we do ask that you complete a brief post-event survey. Please take a moment to complete this survey as it will help Amyloidosis Foundation plan future web events. We are now joined today by our speaker, Dr. Heather J. Landau. Heather J. Landau, MD, is an associate attending physician on the Adult Bone Marrow Transplant and Multiple Myeloma Services at Memorial Sloan Kettering Cancer Center and assistant professor of medicine at Weill Cornell Medical College. She graduated magna cum laude with a BS in biology from Duke University, where she first became interested in the field of hematology and oncology while studying cell biology. She received her MD from Upstate Medical University, where she graduated first, valedictorian in her class. After an internal medicine residency at the University of Colorado, she pursued her hematology and oncology fellowship at MSK, where she remains on faculty. Dr. Landau has dedicated her career to improving the outcomes of patients with plasma cell disorders, including multiple myeloma and light chain amyloidosis. She has designed, implemented, and participated in national and international clinical trials to enhance efficacy, facilitate access, and increase tolerance of high-dose therapy in autologous hematopoietic cell transplant. She has evaluated novel plasma cell-directed and anti-amyloid therapies for patients with amyloidosis in order to establish safety, efficacy, and increase organ recovery in this fragile patient population. She is a lead investigator on the pivotal trials expected to result in the first FDA-approved drugs for this disease. Integrating genomic, proteomic, and quality of life assessment tools, she is working to further advance the detection, risk stratification, and management of patients with MM and AL. She has received competitive funding for her work, which has led to over 50 published articles and book chapters. At MSK, Dr. Landau developed an outpatient transplantation program in 2011, which continues to thrive. More recently, she piloted a homebound transplantation program, which is the first of its kind in an urban setting in North America, and she has been transformative for patients and caregivers' quality of life. She has developed a multidisciplinary amyloidosis program at MSK that is internationally recognized, mentoring residents and fellows who have gone on to seek academic appointments across the nation. Her commitment to medical education has made far-reaching impact. As a thought leader in the world of plasma cell disorders, Dr. Landau is a sought-after national and international speaker. She is heavily involved in several local, national, and international societies. She serves on several committees within the Bone Marrow Transplant Clinical Trials Network, CIBMTR, Plasma Cell Disorder Working Group, International Kidney Monoclonal Gammopathy Working Group, and as an advisor to the Amyloidosis Research Consortium and the Amyloid Foundation. While she exhibits unwavering dedication to her patients and career, her greatest passion is her family, including her husband Dan and her children Samantha, Harley, Sage, and Zyle. We will now play the presentation.
So I wanted to start out with a case presentation. A 55-year-old woman who was previously physically active noted a gradual decrease in her exercise tolerance over 3 to 4 months. She was previously a runner and now had to rest after climbing one flight of stairs. She noted recurrent small bruises on her eyelids for about 1 year. and was evaluated by a dermatologist who could not identify a cause. She then sought medical care from her primary care physician, who noted normal vital signs, minimal periorbital bruising, normal heart sounds, and her physical exam was only significant for a little bit of lower leg swelling. Her primary care physician did labs, and she had a normal blood count and chemistries that were not thought to be remarkable. Her EKG was not normal, but this was overlooked. Her echo showed normal heart function and slightly thicker than normal heart, but this was attributed to possibly hypertensive heart disease. There was no cause identified for her symptoms, and her primary care physician suggested she should follow up in 4 months. However, she continued to feel worse and went back to her primary care physician. At that point, he looked at her prior labs and appreciated that her protein in her blood was lower than expected. He sent her for a 24-hour urine collection, and she had 6.5 grams of protein in a 24-hour period, which prompted him to recommend a kidney biopsy. It was then that they found amyloid deposition in the kidney. A bone marrow was performed, and 9% lambda-restricted plasma cells were seen, and she was diagnosed with amyloidosis of the kidney. Further biomarkers were done, and she was actually also found to have cardiac disease. So what is amyloid anyway? Amyloid comes from the term amylum, which means starch, and was coined by a pathologist who noted extracellular material in autopsy specimens, and it's really a protein misfolding disorder. Here I show a normally folded protein, but when this protein that the cells make misfold into this structure, they can form amyloid fibrils and deposit in certain organs. There's over 30 different proteins that can lead to this amyloid folding pattern, and depending on the protein precursor, deposition could be in distinct organs with very different symptoms, and is most important to recognize that each type of amyloid may need very different treatment. Here I show 4 different precursor proteins: transthyretin, apolipoprotein A, lysozyme, and an immunoglobulin kappa light chain. Each of these 4 proteins have the propensity to form this structure called a beta-pleated sheet. And once these proteins form this beta-pleated sheet, the native protein is not discernible. The beta-pleated sheet can form these protofilaments, which wind together to make the amyloid fibrils. The amyloid fibrils is the substance that deposit in the organs and intercalate this Congo red stain and give this apple green birefringence under polarized light microscopy. In addition, these can be identified in tissues by characteristic diameter under electron microscopy. So AL amyloid is a plasma cell disorder. This is one type of amyloid where the initiating event is an abnormal plasma cell clone that resides in the bone marrow, and the abnormal plasma cells make antibodies made up of a heavy chain and a light chain, and it's this entity, the light chain, that misfolds and deposits as the substance called amyloid. The facts about light chain amyloidosis: it's the most commonly diagnosed type of amyloid, but it's actually not the most common type of amyloid. Now that we appreciate transthyretin amyloid as the result of a either mutated or misfolded wild-type transthyretin protein, produced in the liver is becoming more common. However, focusing on light chain amyloid today, we know that it is rare-ish because it's 1/5 as common as the related plasma cell disorder, multiple myeloma, but it's almost surely underdiagnosed and underrecognized. So I think the true incidence is really has not been determined. On average, patients present in their mid-60s. There's a slight male predominance, and there's no racial predilection. Light chain amyloidosis can be distinguished from other plasma cell disorders, such as the more common multiple myeloma, which is a more proliferative disorder with characteristically greater than 10% plasma cells in the bone marrow, and end organ damage attributable to those abnormal plasma cells. On the left, we see MGUS and smoldering myeloma, where both are asymptomatic, one with a low burden of plasma cell disease and one with a higher burden of plasma cell disease. But again, both entities, there is no organ damage attributable to the plasma cell disorder. Where amyloid fits in is in 60% of patients, there will be a low burden of plasma cell disease, but the characteristic end organ damage attributable to the amyloid deposition in organs. However, in about 40% of patients, there'll be a greater burden of plasma cell disease and the end organ damage attributable to the amyloidosis. I mention this because often in the community, patients with greater than 10% plasma cells and amyloid-related end organ damage will be characterized as smoldering myeloma or multiple myeloma plus amyloidosis and are at risk of being treated with drugs that were designed to treat patients with multiple myeloma, which can be toxic to patients with amyloidosis. Here I show the most frequent symptoms patients with amyloid present with, and these are very nonspecific symptoms that mimic symptoms seen in more common disorders. This leads to an average number of doctors of 4 that patients seek advice from before they are diagnosed. And in a survey that we've done with the Amyloid Research Consortium, among 443 patients and caregivers, 220 cardiologists were named who missed the diagnosis. Here I show the most common organs that are involved in light chain amyloidosis. This large tongue is very characteristic of light chain amyloidosis, although it's only present in about 20% of patients. Periorbital bruising, or these raccoon eyes, is similarly characteristic, but again, not seen that often. You can see here this thickened left ventricle of the heart, which causes patients to have cardiac congestive heart failure. When the kidneys are involved, the filtration system called the glomerulus is disrupted by amyloid deposition, leading to protein loss in the urine. GI involvement can lead to occult or overt bleeding and a large liver when amyloid is deposited there. Sensory or autonomic neuropathy is also common in this disorder, with sensory symptoms consisting of pain, numbness, and tingling, and autonomic dysfunction causing low blood pressures or gastric dysmotility. How do we diagnose the disease? The most important piece is that one can't diagnose this disorder unless there is a clinical suspicion. Once there is a clinical suspicion, a biopsy of the involved organ is necessary. While these tests can identify amyloid in tissues, it's really laser microdissection and mass spectrometry, based proteomics that actually can identify the type of amyloid. When a biopsy of an involved organ is not available, we can biopsy surrogate sites such as fat pad aspirate. In summary, light chain amyloidosis is the result of a small pathologic plasma cell clone that produces an abnormal antibody where the light chain is unstable, misfolds, and deposits as amyloid fibrils in organs, with the heart and the kidney being the most commonly affected organ. We also know that certain light chain variable genes have a predilection for certain organs, and the extent of cardiac involvement is the most important determinant of survival. That has informed the cardiac biomarker staging system, where the biomarkers troponin and NT-proBNP both have independent prognostic implications on overall survival, and patients can be separated into 4 stages based on these markers. Similarly, there's now a kidney staging system based on the degree of proteinuria and kidney function, where patients can be separated into their risk of progressing towards dialysis. In order to treat the disease and improve organ function, we target the plasma cells to reduce the circulating light chains, and when that occurs, organs can improve and overall survival can be extended. The hematologic response is based on the serum free light chain assay, which measures the circulating free light chain, which is the pathologic entity that causes the amyloid. Patients who have a complete hematologic response have superior overall survival, whereas patients who have no response do poorly. The likelihood of organ response is closely related to the depth of hematologic response, and if we can eliminate the pathologic plasma cell and turn off the factory that's producing the abnormal light chains, there is a higher likelihood that organs can improve. We also know that in some patients, even a small amount of abnormal light chain can be pathologic, and we are figuring out ways to reduce what we call minimal residual disease to detect even an abnormal light chain at the lowest level available, and when we can achieve minimal residual disease negativity, the likelihood of organ improvement increases dramatically. We have validated criteria of hematologic and organ response, which predict improvement in overall survival and reduced risk of progression to dialysis. Moving on to the treatment of amyloidosis, the standard of care is to separate patients into transplant eligible and ineligible, although we have to recognize that there's not a single FDA-approved drug for this condition. Historically, melphalan and prednisone was the mainstay of therapy because it was the first regimen that resulted in a response rate. That informed the Boston group to study high-dose melphalan and autologous stem cell transplant, and I'll walk you through this slide where the patient is mobilized with growth factors such that we can collect and freeze the stem cells. That gives us an ability to treat the patient with toxic chemotherapy and or radiation in order to target the abnormal plasma cells in this case. And then because the high-dose chemotherapy is not only toxic to the abnormal plasma cells but also your normal blood-forming cells, the patient can be rescued by reinfusing the stem cells, and that's called an autologous stem cell transplant. So the Boston group first studied this as it was being studied for multiple myeloma, and in 1994, the first 5 patients were treated. 3 of the patients achieved a complete hematologic response, and all 5 improved their organ function. This informed a larger experience where over 300 patients were treated with high-dose therapy, and what we learned from this group was that patients who achieved a complete hematologic response had a better outcome than patients with less than a complete hematologic response. Similarly, patients with cardiac involvement fared worse than patients who had no cardiac involvement. We also appreciated that toxicity during high-dose therapy was closely related to age, cardiac involvement, and renal dysfunction. This informed the original high-dose therapy trials that we performed here at Memorial Sloan Kettering, and patients who were eligible for transplant were separated based on age, cardiac involvement, and renal compromise, and were given differing doses of melphalan. Once transplanted, we restaged patients after 3 months, and those who had a complete hematologic response were observed, and those with less than a complete hematologic response received consolidation with novel agents. Overall, this strategy has resulted in excellent outcomes, and in the median follow-up of 7.7 years in 143 patients, the overall survival was upward of a decade. We do note that there is a drop-off initially, with 8 patients dying within 100 days, for a treatment-related mortality of 5%. Not surprising, 7 out of 8 of these patients had advanced heart disease. There were no early deaths in the patients with the highest dose of melphalan, and this really informs us that it's not actually the dosing of melphalan that results in treatment-related mortality. It's actually the reasons why we dose reduce. But we think that with refined patient selection and risk-adapted melphalan dosing and the use of post-transplant consolidation, we've really improved outcomes. While patient outcomes improve, we have to appreciate that organ responses evolve over time. I show you here an example of a patient who was transplanted in July of 2008. This is a graph of her involved free light chain, her free lambda, at the time of her transplant. After her transplant, she had no significant reduction in her free lambda light chain. However, with Velcade-based consolidation, her free light chain quickly normalized, and actually now in 2019, at our last follow-up, remains in the normal range, independent of any other plasma cell-directed therapy. More important, it's necessary to appreciate that she had 21 grams of protein loss in her urine at the time of her presentation. And despite going into a hematologic remission in 2008 with bortezomib and dexamethasone, it took years for her protein in her urine to reduce, and it's only now in the year 2018 that it's now undetectable. What you can also appreciate is that her serum albumin, which is a measure in the blood of how much protein loss is in the urine, was frankly abnormal when she presented in 2008, and it took 4 years to normalize. I show you this because patients who even have a hematologic remission need ongoing supportive care, as mentioned here. However, with effective plasma cell-directed therapy, patients can do quite well, and disease-related mortality in our transplant population at 2 years was 11% and increased to only 22% at 5 years, where the risk of death from other causes is now approaching the risk of death for amyloid. However, we still have this early drop-off, which again is attributed to patients who are diagnosed in the advanced stage, and the only way that we'll be able to remedy that is by educating the community in order to improve early recognition and treatment. There's also this second drop-off here, which I think is related to not having any effective salvage therapy. Again, there's not one FDA-approved drug for this condition, but I'm happy to say that we are now studying several different treatment options, and the anti-CD38 antibody daratumumab has really been a boon for this condition. In terms of patients who are not transplant candidates, this is a busy slide of multiple regimens that have been studied in phase 2 settings, which are difficult to compare to one another because of different patient mix and characteristics in each study. The choice of upfront therapy is still dependent on patients who are transplant eligible or ineligible, and the ideal patients to receive an upfront risk-adapted melphalan-conditioned transplant are shown here. The 3-drug regimen, Thibor-D or bortezomib-melphalan-dex, include an alkylator, the proteasome inhibitor bortezomib, and the steroid dexamethasone. Thibor-D is preferred in the United States, where BM-dex has been preferred in Europe. Patients with high-risk disease really represent an unmet medical need. These are patients with advanced cardiac disease, and we often give them reduced doses of bortezomib and dexamethasone or low-dose combinations, and they require intensive support. In terms of treating relapse disease, ixazomib, the oral proteasome inhibitor that followed the development of bortezomib, was the first drug to attempt to get FDA approval, and is being studied in a randomized trial. However, due to logistic issues of the trial, it is unlikely that this is going to move forward. We and others have studied bendamustine, which has a response rate in patients who were heavily pretreated, as well as the third-generation proteasome inhibitor carfilzomib, which again has a response rate in heavily pretreated patients. However, this is not a useful drug for patients with cardiac involvement. The immune modulating agents, namely lenalidomide and pomalidomide, also have a response rate in amyloid, but toxicities again do occur: myelosuppression, hypotension, cardiac arrhythmias, and syncope. And while these class of agents are routinely used in patients with multiple myeloma, they're more difficult to tolerate in patients with light chain amyloidosis. While classically all of our therapies have targeted the pathologic plasma cell, we're now studying novel approaches Antibodies have been developed to cell surface markers, as well as the serum amyloid protein that's ubiquitous in amyloid fibrils. More recently, antibodies to soluble light chain oligomers or amyloid fibrils have been studied, whereas these antibodies bind to the amyloid themselves and stimulate the immune system to clear deposits. Daratumumab, which is the antibody to the CD38 on the cell surface in heavily pretreated patients, has been shown to reduce circulating light chains, and this is a percent change in reduction of the free light chain from baseline, with all patients having some response. And this response was found to happen quickly. This informed the phase 2 study of daratumumab in relapsed amyloidosis, and this is actually the hematologic response after one dose, not one cycle, but one dose of daratumumab, with 80% of patients achieving a very good partial response, 90% of patients achieving an overall response. We are now studying daratumumab as part of a phase 3 trial where CyBorD is the backbone, and patients are randomized to receive CyBorD with or without daratumumab, and this study is ongoing and hopefully will result in the first drug FDA approved for this condition. In patients with relapsed or refractory amyloidosis, the related antibody isatuximab is also being studied in the context of a cooperative group trial. We are also studying the all-oral induction therapy, ixazomib, Cytoxan, and dexamethasone, as an attempt to reduce toxicity as well as the burden of therapy. And in patients with greater than 10% plasma cells who have the highest risk of relapse, we're studying an approach of ixazomib maintenance, which has been shown to be effective in patients with multiple myeloma. Moving forward, I think that we will have more options to treat patients, not only in the upfront setting, but also with amyloid-directed therapy. Here I list some of the novel agents that are being studied as second-line plasma cell-directed therapy. We also may have the opportunity to facilitate earlier diagnosis. And another question is, can we replace organs that fail? I briefly want to review the SAVE trial, which is spearheaded by my colleague Ray Comenzo at Tufts Medical Center. Because we know that 70% of patients with amyloid have a pathologic light chain encoded by one of 7 germline genes, and we know that almost all of patients have a precursor smoldering myeloma, or MGUS, where an abnormal free light chain can be detected years before amyloid develops in organs. If we look into general practices where smoldering myeloma or MGUS patients with lambda light chain usage and an abnormal free light chain ratio can be screened, and we take patients who are asymptomatic and try to identify with sequencing techniques their specific light chain. In a pilot trial of 20 patients who were screened in over 13 states, we found 18 patients who had germline genes that were characteristic of forming amyloid, and 2 cases were 2 patients were actually diagnosed with having amyloidosis, and this effort is being expanded, and hopefully this is at least one attempt to identify patients earlier. In the absence of identifying patients earlier, when we now have options for plasma cell-directed therapy, but in patients who are not identified early but continue to have organs that remain sick, we have been very successful at providing kidney transplants for our patients who develop end-stage renal disease. Because of the advent of directed donor and exchange programs, we've had 16 patients transplanted here with a median follow-up of 90 months. 13 out of 16 patients are alive and all with functioning grafts. The Boston group also recently published their experience showing a median overall survival from diagnosis upwards of 15 years and an overall survival from transplant upwards of a decade. We've also been very successful at getting cardiac transplants. We've had 5 in the last 2 years and 2 others from earlier years, and all of these patients who were salvaged with new hearts are doing quite well. In summary, early recognition of the signs and symptoms of AL results in early diagnosis, and that is the most important component to being able to effectively treat patients. So when I speak to general medical practitioners, residents, interns, I always urge them to think about the diagnosis of amyloidosis. The goal of therapy is to eradicate the light chain producing plasma cell clone, and when we do, the organs can improve, but it takes time, and that's why supportive measures are essential. High-dose melphalan in transplant is still a standard of care, but I'm happy to say that novel agents and approaches are finally being studied. We still don't, however, have any FDA-approved drugs for this condition, and the NCCN guidelines still say that treatment for amyloid should be in the context of a clinical trial in order to get effective agents approved, and I urge all patients to be treated in this fashion. With that, I'll take any questions.
Fantastic. Well, thank you so much, Dr. Landau. First, we do want to go through a couple of polling questions. So with that said, to participate in the poll, please select the button to the left that best represents your views or experiences. So we'll pull up our first polling question now. The first question is, to get an idea of who's participating in our webinar, if you could please choose the response that best fits you. We'll pause for a moment while we wait for some responses. Fantastic. Thank you so much. Our second polling question. If you are a patient, what type of amyloidosis do you have? Great. Thank you so much. With that, I'll now turn it over to Dr. Landau to go through some questions. Doctor?
Thank you very much, Tyler. I'm just reading the questions here, and it says we have a few from the beginning. The first question is, could you please discuss the differences in approaches and treatments for localized versus systemic amyloidosis? And I think that the two are treated very differently because localized disease is a local problem Sometimes supportive care is really is the only thing that is necessary. However, when the amyloid is deposited in places such as the larynx, which is common, or the airways, and leads to blockages in either place, then surgical excision is really the standard of care. We often see localized amyloid in places such as the bladder, which doesn't require treatment. Even when it's localized to the GI tract, we often use supportive measures and don't necessarily, and treatment isn't warranted. However, when you have systemic disease where the factory making the abnormal proteins starts in the bone marrow and is widespread from the get-go, we treat with plasma cell-directed therapy. The next question is, if you had a bone marrow biopsy, is it necessary to biopsy other organs? Well, that depends. The way we diagnose the disease is typically by proving that there's both a clonal plasma cell disease or lymphoproliferative disease that's underlying, that's producing these abnormal proteins. And if in the bone marrow you can establish that there is amyloid present and you had characteristic organ damage, then one may not need a organ biopsy. However, the bone marrow only shows amyloid in about 60% of patients, so in the absence of amyloid in the bone marrow, if a patient is suspected to have organ involvement, it's essential to biopsy an organ. The other caveat to that is, again, there's more than one type of amyloid that can affect the patient, and so sometimes it's necessary to biopsy the organ in order to type the amyloid and make sure that you know exactly what you're dealing with. The next question is, there appears to be a lack of focus on reducing organ toxicity secondary to chemo, and instead often overly zealously trying to reduce free light chains. It appears to me as both a patient with AL and a hem-onc doc that patients with AL need to be carefully monitored, treatment-related toxicity to avoid early mortality and morbidity. Please comment on this critical issue. I would 100% agree with you that often in the community is where I see this happen most frequently, where the understanding of the disease is where doctors are not as familiar with treating this disease, and I showed that slide where I talked about supportive care is critical. Even in patients who get a hematologic response. So while an early treatment response is critical to improve organ function and extend overall survival, that's not at the expense of causing toxicity for the patient. I think when a patient first presents to me, the first thing before taking out, before even considering what treatment the patient requires is really supporting the patients and optimizing their care, such as patients who present with heart failure need to be put on diuretics, we need to optimize the blood pressure. You can't just throw chemotherapy at these patients. Then if the free light chains don't normalize, you can't just keep pounding the same chemotherapy into the patient to expect to get a treatment response, a hematologic response. Rather, we would suggest to switch therapies if there is not an early response to plasma cell-directed therapy in order to try to facilitate a response. But again, not at the expense of causing toxicity. Is stem cell transplant the best route of treatment for AL and MM? I think that's a difficult question to answer. For many patients, stem cell transplant, which is really a way to deliver high-dose melphalan, is a very effective strategy, but patients who are frail often can't tolerate stem cell transplant, so you have to really pick and choose individuals. You have to really determine transplant eligibility by in individual patients. That's really pertaining to patients with AL amyloidosis. Multiple myeloma patients tolerate transplant much better, and I would say that it's stem cell transplant or high-dose melphalan plus stem cell transplant is still the standard of care in patients with multiple myeloma. There is a question. I thought NEO-D001 trial was stopped because the drug didn't work. Did you indicate that there's a future use of that drug? There was a analysis of a reanalysis of the data. While in all comers the drug failed to meet its primary endpoint, meaning that statistically there was no significant improvement in overall survival. In all comers, there has been a secondary analysis in patients with very advanced disease that there seems to be a benefit in certain populations. However, it's really hard to interpret that data, which was recently presented at a meeting this past weekend. I think that I can't say that there is a definite future for NEO-D001. The good news is that there is another antibody that is still being developed. I think the strategy, we can't throw the baby out with the bathwater, and there's lots of reasons why one antibody may work and one may not. So there's another antibody made by Calum that is still going forward and being studied. I can't say that I know for sure that the treatment will work, but at the same time, I think that we're still hopeful that there will be some future of anti-amyloid antibodies or anti-fibril-directed therapy. There is a question about what about treatment for AL amyloidosis if you don't qualify for a transplant. The good news is that actually in the year 2019, while there's still not one FDA-approved drug for this condition, there certainly being many more active therapies are being studied. Not least of all is this anti-CD38 antibody, daratumumab, and related anti-CD38 antibody, isatuximab. which I think both of those are going to be a very welcome addition to our armamentarium in terms of facilitating treatment for patients who are not transplant eligible. Bortezomib still remains a standard treatment strategy, and in the U.S. we often use bortezomib, Cytoxan, and dexamethasone combination. In Europe, melphalan, bortezomib, and dexamethasone has emerged as a standard regimen. There is a question, where can we learn more about the SAVE trial? I think that actually it is an internet-based trial. I'm not sure if they're still accepting patients, but I would say at Tufts is the lead center, and there should be information on their website. But certainly, if you can't find it, you can get in touch with the Amyloid Foundation, and I can help direct you further. If a person with AL is in a complete hematologic response, is the continued tingling in the hands and feet a symptom to worry about? If not, is there any way to reduce this tingling symptom? That's a difficult question. Oftentimes, patients with AL have tingling in the hands as a result of the disease. However, just as commonly, patients develop tingling in the hands as the result of toxicity from treatment. Most often, bortezomib or thalidomide can cause that symptom. Over time, if somebody's in a complete remission, slowly over time, like I showed you with the renal response, it can take months to years. If the tingling is due to the disease itself, even if you're in a complete remission, that tingling doesn't necessarily go away right away. Often it takes months to years. Similarly, if it's caused by toxicity from therapy, thalidomide-related neuropathy doesn't tend to go away. Bortezomib tends to decrease, but doesn't necessarily resolve. There are medicines that can help manage symptoms, which I would encourage you to speak to your doctor about. There's a question about maintenance versus no maintenance with AL and multiple myeloma. Maintenance is a standard of care for multiple myeloma, which is a more proliferative disease. In amyloid, because the majority, again, I said 60% of patients have a small plasma cell or B cell clone in their bone marrow and don't necessarily have a proliferative disease. Patients who achieve a complete hematologic response can do quite well, and maintenance has not been a standard in AL amyloidosis. However, because we do know patients with greater than 10% plasma cells have higher risk for relapse and organ progression, we are studying maintenance in that patient population. Is it possible to misdiagnose the type of amyloidosis? Most certainly. And that's why if a patient has a predisposition for two types of amyloid, classically we would say an older Caucasian male who is the phenotype for TTR amyloid, but also has a higher incidence of having MGUS, which is a monoclonal gammopathy present in the blood, then those patients require biopsy of the involved organ as well as organ type, amyloid typing. If the kidneys are damaged, won't the involved and uninvolved free light chains be elevated above normal levels? Absolutely. This is a conundrum. Most often in that time we rely on the free light chain ratio, which if there is a complete hematologic response, the ratio, which was previously either high or low based on an elevation of the involved free light chain, the ratio was abnormal. With a complete hematologic response, the ratio becomes normal, and it's often very gratifying in patients who do develop end-stage renal disease and then undergo a kidney transplant to see that as soon as they get a transplanted kidney and have normal renal function, that those elevated free light chains return to normal. If one is diagnosed with lambda AL, can elevated kappa light chains as a result of kidney failure be used to seed these fibers, as fibers are heterogeneous in a mix of lambda and kappa? We don't really, that's a great question, but oftentimes, while there could be some kappa light chains deposited in an amyloid fibril, I don't believe that we believe that the amyloidogenic light chain is the result of a specific mutation in that light chain. So that specific mutation will cause that light chain to misfold and be the seed or the pathologic entity for promoting an amyloid deposit. We wouldn't expect two different light chains to have mutations in the same patients. Is it necessary to do bone marrow biopsies every year while in remission? That depends. When we follow patients on clinical trials, there's sometimes good reason to do the bone marrow biopsy, especially if we're studying minimal residual disease. However, if somebody's not being followed on a clinical trial, it's unlikely that doing the bone marrow test each year will change our management. Who might be a candidate for lower dose melphalan during a transplant? Typically patients who are older than age 70, patients with cardiac involvement, patients with compromised renal function. We are now studying a strategy where we use pharmacokinetics to understand how melphalan is handled in individuals such that we always give the same dose to everybody. But if we can figure out how we give the same dose to everybody, but we know that that means that each person is seeing a very different dose depending on the way the way a patient's body metabolizes the medicine and the kidney function and the liver function. So now we're trying to study a way to target a specific dose within individual patients. And stay tuned for more on that. And maybe we can actually identify a sweet spot in terms of dose to improve toxicity and limit, to maximize efficacy and limit toxicity. Can you envision a time when the standard of care, gold standard of amyloid treatment is not stem cell transplant? I think so. I think that there will be patients who respond to some of our newer medicines and don't require a stem cell transplant. I can't say that for everybody that it is going to be a panacea, and that I would not say that. I think that it's useful to have stem cell transplant again as a possibility, because there will be patients who, even after achieving a complete response to more of our novel therapies, may need salvage therapy, and hopefully that those numbers are reduced moving forward. But again, patients who do well with stem cell transplant, and we are getting better at defining the best players to have the procedure, and also the best way to support patients, and again, these targeted dosing, that even transplant becomes less toxic and more effective moving forward. Similarly, a patient asks, I responded well with therapy and never had the stem cell transplant. Why is this? I went into remission and decided not to do the transplant. Why is this? That's exactly what I'm saying. If you achieve a complete hematologic remission, a very deep remission, and the organs can improve, then it's not necessary to pursue the stem cell transplant. I would, of course, encourage everybody who was once a stem cell transplant candidate to have their stem cells collected. But again, if you have AL amyloidosis and you achieve a very deep remission, it probably does not matter how you got there. Is cardiac troponin T or cardiac troponin I the preferred troponin lab test? Mayo uses T and Stanford uses I, and is there any head-to-head published literature on this issue? No, I think that both have been studied, and both are independent predictors of survival. So whichever lab is being used, I think, is reasonable. When do you need to restart chemo after achieving a response after 5 cycles of CyBOR-D for early diagnosis with translocation 1114 and kidney involvement? hard to speak to the specifics of that question, but certainly if patients achieve a complete response and stay in a complete response, you don't necessarily need to resume treatment. I think that we can often see by blood tests if patients start to progress, and we would resume treatment in patients who progress sooner as to not develop worsening organ function. Is the AL mutation due to a genetic predisposition or exposure to some agent combo of agents? A maternal aunt passed away in 1994 of myeloma, and I was diagnosed with AL in 2014. Spent 10 years in chemical engineering, 20 years in computer work. Which is more likely to cause the mutation, genetic predisposition, or some type of toxic exposure? That's a very difficult question. Our antibodies, our plasma cells produce antibodies as the result of exposures all the time. So that's the function of a plasma cell is to produce these antibodies, which by nature are constantly mutating in order to target specific pathogens that we're exposed to. And whether there's one exposure that, whether it was a chemical exposure versus other antigenic stimulation that caused you to produce a amyloidogenic light chain, it can't be discerned, at least for now. Whether or not this has anything to do with your maternal aunt who passed away of multiple myeloma is, it's really probably very unlikely that that's the case. What is the relationship of translocation 1114 to AL? It is the most common cytogenetic abnormality that we see in the pathologic plasma cells. It's also common in multiple myeloma, but much more common in AL. How long does someone with AL amyloidosis have to continue chemotherapy treatment? That really depends on lots of factors. Number one is the degree of remission in terms of the depth of remission, of hematologic remission, and the proliferative or non-proliferative nature of the clone. And I think it really takes, it's more of an individual decision, and it's not really cookbook medicine. Most patients, we say 6 cycles of chemotherapy, certainly less if you're having toxicity. And if the disease was, say, refractory to treatment 1, 2, and 3, we'd probably keep you on a disease treatment that you're responding to longer. in someone with a VGPR post-transplant, what are the markers, changes, threshold when additional therapy is indicated? That really depends on the organ involvement. Oftentimes in patients with cardiac involvement, VGPR, may or may not be enough to prevent organ progression. In somebody with renal disease, oftentimes patients improve when they have achieved a very good partial remission and don't necessarily need a complete hematologic remission. I think that is all of the questions. Tyler?
Fantastic. Well, if those are all the questions, Dr. Landau, I'll turn it back to you for any closing comments before we conclude here.
I would say that I hope this was educational. I think that the biggest issue we have as treating physicians is that patients are not being diagnosed early. Early diagnosis leads to less organ involvement, and so one of the goals of experts is to really educate the community and facilitate earlier diagnosis. And I guess the last closing thought to patients who are already diagnosed, participation in clinical trials is critical for us to study drugs which may or may not be effective, but at least if we have patients participate in clinical trials, then those that are effective can be offered to patients moving forward.
Fantastic. Well, thank you so much, Dr. Landau. And with that, we will conclude our presentation. So on behalf of the Amyloidosis Foundation, I would like to thank you all for your participation in today's event. A post-event survey will appear requesting your feedback, so please take a moment to complete this survey as it will help the Amyloidosis Foundation plan future web events. This concludes today's program. Thank you all, and have a great day.